Prof. Nasir is currently our general and upper GI surgeon in Sultan Ahmad Shah Medical Center. He graduated from University of Colombo and later on obtained his FRCS in 1990. So he's actively involved in teaching undergraduate as well as postgraduate students in surgery. So Prof. Nasir, the floor is yours. We look forward to your talk.
Okay, Assalamu alaikum warahmatullahi wabarakatuh. Sorry, I have put the video off so that the screen can be full, and also for internet interruptions and whatnot. I hope you can hear me.
Loud and clear, Prof. Nasir, thank you.
Okay, thank you. Okay, my topic this morning is principles of organ transplant. Unfortunately, I don't think any of you all would have experienced or seen organ transplants because it's not a common problem or common operation that's carried out. Anyway, I'll try my best to maybe highlight a little bit of the principles, okay? Okay, with regard to these are the sort of the outline of my presentation. It's better from your point of view to know the terminologies that are used in organ transplant, understand the basic principles with regard to immunology involved in organ transplant, the contraindications for organ transplant, and organ matching and retrieval, okay? There is also very important to understand what is referred to as immunosuppressant therapy. Then a little bit of the most common thing that is common organ that is transplanted, which is the renal, okay? Advances in surgical techniques, different types of surgery, and also advances in tissue typing and high advancements in drug therapy. Pharmaceuticals have sort of resulted with successful, very high degree of successful transplantation of organs. This is not so much in this part of the world, but more so in the Western world. Okay, but it's very important to ensure that these organs are sort of obtained following the accepted norms. That is, you have international and also national guidelines and policies that you got to follow, okay? You shouldn't resort to unethical practices where there are reports in other parts of the world where people are kidnapped and on the following day they wake up with a scar in the abdomen, which shouldn't be the case. You got to remember that organ transplants itself is not a cure, but just a treatment to sort of improve patients' quality of survival with regard to whatever organ involved, and also some degree of survival benefit. And it involves a MDT, a multidisciplinary team, which involves transplantation surgeon, physician, maybe dietitian, pharmacist, very important, counselors, and also very important to know that this organ transplant procedure itself involves a very high degree of coordination. As such, a coordinator is very important, okay? When you take the history of organ transplant, the French surgeon by the name of Alex Carrel, who was actually a surgeon in Lyon, he has been sort of recognized as one of the pioneers. Just a note that he failed his exam several times. As a result, he couldn't practice as a surgeon in Lyon. And he went over to the States in Boston, where he worked with a pathologist, if I remember right. And he was instrumental in experimenting a lot of vascular surgical procedures. And he was the first one who transplanted organ in a mice. For his work, he actually won recognition and won the Nobel Prize in Physiology. But the actual procedure itself, human transplant, was done by a Russian surgeon somewhere in 1934, if I remember right. And he carried out transplant without any compatibility procedures. As a result, it was actually kidney transplant, unrelated patient, donor, and as a result, the organ packed up in 2 days, and the patient died without producing a single ml of urine. Just one more thing. With regard to the actual transplant itself, successful transplant was done by an American by the name of Murray, a surgeon, who carried out kidney transplant, successful kidney transplant. Just to highlight some of the terminology that are used in organ transplant, autologous transplant organ itself is a bit unusual, maybe skin and flaps and all. That's what we do. The allogenous transplant is the most common one. You have a recipient, a donor, but the donor is better if it's a relative. You get a better success rate, but it can be others as well. Isograft transplants are done among genetically sort of identical individuals. So they are maybe identical twins, okay? Xenograft transplants are not commonly carried out. There have been experimental studies where a baboon's heart has been transplanted to a human and things like that, but it was not very successful. It's from another species, so is still in the sort of research stage. The other terminology that you should remember is disease donors or cadaveric transplant, where organs from disease people are harvested and given to recipients, but usually they are given to recipients on a sort of waiting list, okay? The live donors is one of the common sort of things that's happening now, where a healthy person chooses to donate either his organ or maybe part of his organ to a person who needs it. You got to remember that sometimes there's a terminology called directed donors. That means you already identify whom you want to give, maybe a relative or a friend or whatever. But you get non-directed donors. These are people with good intention, okay, who feel that they should do some service to humanity and they decide to donate, okay. So these are the two types of sort of live donors. Okay, just to understand, sorry, I don't know how to get rid of this. Okay, just to understand the immunological principles involved in transplantation. I'm sure most of you are aware about the MHC proteins that are found in leukocytes or human leukocyte antigens. These are the sort of proteins that are found on the surface. of almost all cells except maybe RBCs, okay? What it gives the identity to the cell to recognize itself and also tolerate itself without being destroyed. And it is involved in antigen presentation with regard to organ transplant, okay? There are 6 genes that are very important. There are hundreds of genes that are found on the surface, but these 6 genes are the genes that are involved in or plays a crucial role in organ transplant. These are the class 1 genes that HL, A, B, and C, and the class 2 genes, which are the HLA, DP, DQ, and DR. The class 1 genes, as I mentioned, expressed in sort of all cells, and is very important with regard to the intracellular part of antigen presentation. But class 2 genes are expressed only in APCs or antigen presenting cells, maybe mature dendritic cells, macrophages, and B cells. Okay, they are responsible for the presentation of extracellular antigens. Okay, and also I'm sure you can recollect there are 2 types of immunity in an individual, which is the natural one and also the humoral immunity. Natural is obviously is non-specific and doesn't have any memory as such, but it is the first line of protection against any attack on the human system. But the humoral immunity is antigen specific and has some memory. Okay, so this and also cytokines obviously plays a very crucial role with regard to development and also the differentiation of these immune cells, right? And just to highlight, I'll sort of try to explain it a little bit later. These 2 types of immunities sort of can activate each other and also plays a very important role in transplant rejections, okay? Even immediately after transplant, the ischemia reperfusion injury during transplantation obviously causes the dams to be to activate the innate system, which sort of result in tissue damage and release of donor antigen, which can cause either immediate damage or subsequent damage and early transplant rejection. Okay. As I alluded to earlier, this sort of process is called allorecognition. It can involve both B and T lymphocytes as well and give rise to rejection. Okay. This rejection risk also increases. This sort of same things happens in when there is sepsis and infection in these patients who end up with organ transplant because they are on immunosuppressive therapy and can end up with sepsis and infection. There are 2 types of recognition that maybe you allorecognition that you got to remember. One is the MCH molecular that are on the allograft are very strong antigens and directly can stimulate the D cells without it being broken down and being presented by the APC of the recipient. It can directly stimulate the cells and cause rejection or create environment for rejection. And sometimes there is what is called indirect allorecognition. I'll show it a bit later on a diagram, which is basically the molecules obviously on allograft are sort of different from obviously those of the recipient, and they treat it as some foreign antigen. Okay, so by the antigen presenting cells and the antigens are then broken down and presented by the APC. Is the antigens are broken down and presented by the direct recognition is where it directly stimulates T cells. Okay, and the importance of this is this sort of T cells by this HLA, the peptide sort of results in a particular clone proliferating, which, right, is a particular, the same sort of type of T cells. And this is sort of mediated by interleukin 2 and all, complements and whatnot, and leads to sort of acute rejection. So this is T cell mediated. Okay. What are the cells of innate immunity? Just to understand the basic, they are basically the macrophages, the immature dendritic cells and all. As I alluded to earlier, they produce the first response, okay? And they remain local, okay, at the site, and are the sort of most important antigen presenting cells is very important. The dendritic cells more than macrophages. Okay, so the other adaptive or humoral immunity is where you have different types of cells, the T cells, which either could be helper cells, which is CD41, or the T cell CD8, which are actually produced in the thymus. Okay, all these T cells have T cell receptors and require sort of APCs to develop into memory cells. Okay, antigen presentation, so that this is very vital in rejection of grafts. Okay, the CD8 or cytotoxic cell mature into memory T cells in the sort of peripheral lymph organs like lymph nodes and spleen and all. And when their receptor binds to the class 1 antigen complex, as I told you, I will show it in a diagram in my next slide. They form the complex on the antigen presenting cells. You have the T helper cells, and also these actually form recognized antigens, and they get the secondary lymphoid organs are involved, and these binds and with the MHC2 antigen complex, which I alluded to earlier, the two types of antigens that are involved, the genes, and these differentiate into specific T helper cells. Okay, these are very important to understand the T cells, and the B cells have another function. They have IgD on their surface, but these recognize the allo antigens that are present in the donor organs, and they undergo class switching. They can switch into any of the other immunoglobulins, Ig, E, A, and M and all, and they become memory cells. These memory cells are very important for organ rejection. So this is why it's very important to know a little bit. If you find it a little difficult to understand, I think it's always better to go back and maybe read it up a bit. Okay, so this is how rejection occurs. If you see this is sort of direct, as you can see, the APs are present on the lymph node, they directly stimulate the T cells and helper cells. And helper cells are involved in B cell formation, which I alluded to earlier. So this is how rejection occurs, okay, either directly or indirectly. Okay, just to sort of make you understand a little bit, okay, as I mentioned earlier, the antigens that are found in the donor organ is sort of identified, captured by B cells in the peripheral lymph node. And there is this class switching I told you about, the IgG antibodies turning into different types of antibodies. And there is what is called memory B cell formation. These secrete antibodies, okay, against the donor antigen. And these are the main MHC antibodies. And these antibodies sort of opsonize the draft cells. And this sort of antibody-dependent cellular cytotoxicity capability, okay, and also combined with the complement system, attack the opsonized cells. And this process causes antibody-mediated rejection in addition to cell-mediated rejection, okay? The other thing is just to know the different phases of rejection is very important, at least you to understand what is meant by hyperacute, which I mentioned just now, antibody mediated, right? There is pre-existing antibodies and this, just the one I mentioned just now with complement activation, this causes thrombosis. And there is rejection within minutes to hours and the organ packs up, right? That is what is called a hyperacute. The acute one, okay, acute one is due to the cellular response, that is activated lymphocytes, and this can occur around about 6 months, right? And there is also humoral rejection due to anti-donor antibodies as well after transplant, which is not very common, but it can happen. Chronic rejection is where antibody and cell-mediated rejection of the may is a combination of both and may take months to years. Okay, so these are the three terminologies with regard to rejection. Okay. With regard to prerequisites for sort of organ matching, very important to know with regard to compatibility. The recipient donor should be ABO compatible, and also there is matching, cross-match of the serum to make sure there is no obvious antibodies present that can cause a sort of a hyperacute rejection, and also the HLA testing, which I alluded to earlier, the six main genes that are involved in organ transplantation. Okay. With regard to cross-matching, by the way, with regard to ABO, I don't want to, ideally, there should be ABO compatibility. RH is not that important, but ABO compatibility is very important with regard to transplant. But there have been a lot of studies, especially they have actually done transplants mainly arising from Japan, where they have done on patients who are ABO incompatible as well. And they have produced relatively decent results. So these are new things that are happening. The other one is, as I told you, cross-matching. You are actually looking for preformed antibodies that are donor-specific, okay, in the recipient serum. And you are looking for donors sort of T and B lymphocytes. As I mentioned earlier, the direct sort of rejection, okay, or allo recognition, the direct allo recognition. So when you look for these T and B lymphocytes, if there is a negative cross-match for these two lymphocytes, the rejection will be relatively low in these patients. But if there is negative for T cells, but if it is positive for B cells, there is a higher risk of acute rejection. Okay, but if both are positive, then there is a very high chance of a hyperacute rejection, so you shouldn't proceed with the transplant. Okay. The tissue typing, as I mentioned just now, there are these 6 main sort of genes that are involved, or proteins that are involved with regard to transplant. Okay, usually we get 3 from each parent, but it's rare to get sort of 6 antigen matching this between 2 people, donor and recipient, unless they are either identical twins. Okay, or maybe there may be a high chance of a match if they are related, but if they are unrelated, very unlikely. But you got to remember that there have been a lot of transplant even without proper matching due to the advancement with regard to immunosuppressive therapies, okay, to prevent rejection. The other thing about transplant is to understand or to know the contraindications. Okay, if you are taking organs from deceased donors, then obviously there are some absolute contraindications that you should be aware. That if the patient has active cancer, organs shouldn't be taken. But then there is a little bit of relaxation, because if the patient has had cancer and has been sort of relatively symptom-free without any evidence at all for about 5 years, then those patients can have their organs transplanted. Okay. Transmissible disease, AIDS, hepatitis B, C, and all. But again, if they have been treated and asymptomatic, then there is evidence that these patients' organs too can be harvested. Age, it is a bit arbitrary, because it depends on what particular organ that you are planning to transplant. Okay. But the absolute age, of course, is beyond 75. I don't think those organs are any good, isn't it? Anyway, chronic organ failure, whatever patient had, then is pointless trying to transplant a failed organ. Uncontrolled infections, the new addition is Alzheimer's, and Creutzfeldt-Jakob disease, right? All these patients, I think, there is absolute contraindication. Okay. Okay, there are some relative contraindications, which are diabetes, hypertension. You've got to check, but if they are well controlled, the organs are fully functional, maybe there is a place for harvesting their organs. As I mentioned with regard to age, for heart, I think transplant teams don't practice taking patients beyond the age of 60 years. And for pancreas transplants, it should be less than 45 years. Okay. With regard to contraindications in the recipients, if the recipient has a malignancy within the past 2 years, it's not advisable to have organs transplanted in them. Lack of adequate support for the patient, especially from family and also welfare support, because these people need a lot of care after transplant with regard to monitoring and the side effects of immunosuppressive therapy. Regard to patients who are non-compliant with their medical regime, is it advisable not to transplant? If they are diagnosed with major cardiovascular disease, again, same thing, significant sort of coronary artery disease, and obviously if they are malnourished and cachexic, you wouldn't transplant. Okay. A few words about living donors, which I told you is a little bit in vogue at the moment, so you got to understand a bit. Usually these organs are harvested either from a relative or friend who wish to donate part of their organ to another person. The main ones are the kidney and liver transplants. Okay. Contraindications are, if again, as almost the same as I alluded to earlier with regard to these living donors as well. Okay. The advantages of transplant in living donors is that donor is relatively in a good condition. And there is immunomodulation during sort of either preoperative or even during perioperative period. And there is short sort of cold ischemic time. I will explain to you what is cold ischemia, warm ischemia. And also minimal waiting time. If both parties agree, you go ahead with the transplant. And if it is a relative, there is a higher degree of compatibility. So as a result, the success rates are high. But one of the major disadvantage of this is with regard to increased morbidity and also mortality in the donors, okay? In the donors, not the recipients, okay? And a few words on organ preservation once you have harvested. Currently, static cold storage is the one that is a standard method. But there have been a lot of advances where because this cold storage can be only to a limited period, but advances have been made where they have developed perfusion machines and whatnot to keep this organ functional, right? So it is sort of the advancements that are in vogue at the moment. Okay, so maybe during the next couple of years, maybe the next decade or so, this will come into sort of standard practice. The normal sort of hypothermic solutions that are used are the University of Wisconsin solution, which is the intracellular solution, and the other Brezhnev solution, which is the sort of extracellular ones. But I don't think you got to know the details of this as long as you know the names of these solutions. The other one is obviously the British one, St. Thomas cardioplegia solution. Okay. At the ischemic time, there are two terms that are usually used with regard to organ transplant. Warm ischemic time is where you take you withdraw the life support. Say you are decided to harvest an organ from a patient, a living donor who is in a life support, and then you withdraw it, right? And take it, and then you put it on cold or preservation. At that period is called warm ischemia time. Okay. And the cold ischemia time is from the initiation of the organ storage to warming the organ when it is transplanted. Okay, when it is transplanted. That is a cold ischemia time. So that's what I mentioned is the period, the cold ischemic time is very short in a sort of living donor transplantation, because sometimes it can be two adjoining OTs and you take from one OT and transfer it to another OT, where the donor is in one OT and the recipient is in another OT. Okay. The other thing to note is with regard to transplantation sites. Okay, transplantation sites. Sorry. That is where you place the donor's organ, okay, on a recipient. There is what is called the orthotopic sort of transplantation, where the graft is placed in its normal anatomical position. Like if you remove the heart, you can't place the heart somewhere else, obviously, is placed in the normal position. Okay. And the non-functional organ of the recipient is removed at the same time. Okay. It applies to heart and the liver as well. Okay. There is what is called heterotopic, where the graft is placed in a site other than the normal anatomical position. Sometimes the non-functional organ is either removed or left in place. So the common is the kidney transplantation that most of you have seen or encountered patients with, and very uncommon in this part of the world, but common in the Western world, is pancreas transplantation. And there is what is called paratopic, that is placed in close proximity to the normal position. So again, sometimes pancreatic transplantation is done in this way. Okay. Then a few words about post-transplant sort of immunosuppressive therapy is carried out in the early post-operative period. It has to be intensive for the first 3 to 6 months to prevent rejection. It is always advisable to use sort of multiple drugs, low doses of multiple drugs, than using sort of 1 or 2 drugs which are of very high doses, because you want to prevent post-transplant infection, and also sometimes this patient tend to develop malignancy later on. Okay. The phases of immunosuppression is usually you have the induction therapy and also the maintenance therapy. Usually in the induction therapy, you use anti-T lymphocyte antibody. There is a non-depleting antibodies and also the lymphocyte depleting antibody. Those are the drugs that is mentioned there. You can use either monoclonal drug like basiliximab for non-depleting antibody, and you have the polyclonal like thymoglobulin for lymphocyte depleting antibodies. Maintenance therapy, usually common triple drug regime consisting of steroids, calcineurin inhibitors, and anti-proliferative agents. Okay, so these are some of the common drugs that you will see when you encounter patients with transplant. Okay, one of the objectives of immunosuppressive therapy is to make sure you balance the therapy without suppressing them too much, which can give rise to infection and subsequently compromise the graft, or too little, which can give rise to rejection and again compromise the graft. So you've got to make sure you get the sort of appropriate balance to get a successful outcome. Just find a few words about renal transplantation, because this is one of the commonest things that you will come across in your sort of practice, where you see quite a few patients coming to you, and also exam cases also could be post-transplant, mainly renal transplant. Indications obviously for CKD5, okay. There are some absolute contraindications. Ensure the vascular anatomy is normal. And if the patient has a aorta bypass, but if it involves both external iliac, it's very difficult to graft or transplant on these patients. Sort of circumferential calcification of the major vessel. And this is a general thing which I alluded to earlier, malignancy within the past 2 years or so. Very high BMC, morbid obesity, if they are on substance abuse, and this, as I mentioned earlier as well, you've got to ensure adequate social support. If there is lack of it, then this is one of the absolute contraindications. Okay. There are some relative contraindications. Okay. This is with regard to living donors. That is a person who wants to donate one of his kidneys to another person. Those patients should be not be less than 1 or more than 75 years, and they shouldn't have any urinary tract infections or diseases. Okay, there are some specific contraindications. Obviously, pregnant ladies shouldn't be donating organs, but if the patient has some psychiatric disease or any other disease that leads to kidney or have led to kidney damage, then they should be donating one of their kidneys. If they are diagnosed to have proteinuria, it is another contraindication. If they are uncontrolled hypertensive or diabetes, those are contraindications as well. So these people should be donating their kidneys, okay? Just to say a few words about the technique so that you will understand why you get it in different places of the donated organ or transplanted organ. Usually, if it is a living donor, we like to take the left kidney from the donor because it has a longer renal vessel, okay? And is transplanted heterotopically. As I mentioned earlier, usually in the iliac fossa, because it has some advantages, okay, when with regard to when compared to orthotopic transplantation or implantation. Sorry, it has transplantation. The advantages are if you put it, place it in the right iliac fossa, you can palpate easily. If you suspect any issues with it, you can biopsy. You can regularly sort of evaluate the kidneys using ultrasound, right? And with regard to the procedure itself, anastomosis is very easy in the inguinal region, okay? And also with regard to the ureter being anastomosed to the bladder is very short. So the chances of you ending up with strictures and all are less, okay? So that is why we prefer the right iliac or any iliac fossa, okay? The complications of for renal transplants is acute tubular necrosis, rejection, infection, sometimes vascular issues, leaks, and sometimes very rarely urinary tract obstruction. Very uncommon complication is lymphocyte and the drug-induced. We give say these immunosuppressive calcineurin drug-induced nephrotoxicity. So these are some of the things, and also following this transplant is very important that you monitor them regularly and also ensure that they continue with their post-transplant immunosuppressive therapy. And as I told you, ensure they don't get infection, because the balance that I mentioned earlier with regard to immunosuppressive therapy is very vital. That's why they need very careful monitoring. Okay, with regard to transplant in Malaysia, if you go to the Ministry of Health site, you will see this registry, which is updated till 2015. And also there are some guidelines, a booklet on guidelines. You can browse through them, which you get some idea as to what's happening here. But if you see kidney transplant is very low. If you see from 2008 to 2015, is 2006 to 2015. Initially, it was about 6 renal transplant per million, which has now come down to about 3 renal transplant per million, which is very low, and is very important. I don't know what is the current data is, but you can understand that is why you don't see many patients with this sort of condition. And also liver transplant is, I think when you 2015, there have been only about 10 liver transplants. Okay, 10 total, not 10 per million, 10 total transplants. So very low numbers. Okay. So just there's some information to the Muslim candidates who are out there. There has been a recent about this study done about 2 years ago in UK. Only a third of the Muslim who surveyed actually support organ donation. The survey was done between the ages of 18 and 65, okay? So of those, only 14% actually strongly supported it, okay? But almost, more than that, almost 40% opposed donation. And out of the quarter of them very strongly opposed, which is the problem. I think we have a very false perception with regard to organ donation. And that is one of the reasons why it is not so sort of practiced so much in this part of the world. And the statistics have shown in UK that 3 people die every day who have benefited from some transplant. And there are about 6,000 waiting for transplant. And of those, almost 1,000 are Muslim Asian background people. So you've got to sort of address these issues with regard to rectifying the problem, okay? In conclusion, what I can say is this has been one of the sort of successful advancement in medicine, and still ongoing. There are a lot of, other organs like even there are face transplants as well. I'm sure you have read about it. Okay, pancreas is very common now, pancreatic transplant. Intestinal transplant is another transplant that has been practiced for shortcut syndrome. So there are a lot of bright advancements ahead. I hope you too will be part of it. Obviously, this saves lives actually in patients who have very bad or terminal organ failures. And not only saves life, they improve their quality of life as well. Okay. Unfortunately, the main challenge today is between the number of organs required or the demand for the organs and the availability. Okay, availability. So I think maybe you as future surgeons can contribute in whatever way you can to improve organ availability. In addition to this, as I alluded to, all the sort of patient care, graft survival, and immunosuppressive protocols, optimization, these are also challenging tasks. So these are the main issues that face organ transplant in today's context. Okay, thank you very much.
Thank you, Prof. Nasi. I think everyone can agree that was a very interesting talk since, I think most of us have not seen a transplant surgery before, including myself. So I think we've got a couple of minutes for questions. Any questions from the floor?
Question for Nasi. I don't know if it's related on this presentation or not. I just have a thought that regarding the liver transplant.
Yeah.
Usually we do a autotrophic transplant.
Yeah.
So we remove all the entire lobe, but we replace it with segmental liver. Is it, Prof?
Yes, yes, yes.
So I read before that there has a adult donor with the kid's recipient. Is it the issue of size of the organ will be an issue during the transplant?
Sorry, I didn't get it. Sorry, come again.
The adult donor, liver, and then donate to the recipient is a pediatric age recipient. So is it the size of spaces will be an issue?
It depends. I think first they will match before they accept for pediatric patient. I'm not sure about adult and what type of pediatric patient, whether you're talking about a pediatric patient who is very young or maybe 5-6 years or maybe a bit older. So that's, I'm not sure, but this will be in consultation with the transplantation physician, transplantation surgeon, and the pediatric team are involved in it. So there is no hard and fast sort of absolute answer to that question. Okay. But if you ask me, if it's a very young child, you put an adult kidney, it may be incompatible because, for example, the amount of blood that adult kidney requires per minute may be much more than what a young child's kidney will. So that itself will cause blood supply issues as well. Do I answer your question or is that what you asked?
Yes.
Sorry.
Yes, Prof.
Okay.
One more question, Prof. Regarding the one that you say regarding the pancreas transplant. Is it the whole pancreas or is it a selective? Because I read they do a macam beta islet Langerhans.
Yeah, usually it depends. Sometimes they use the whole pancreas, sometimes part of the pancreas. Okay, but what they do is they transplant it adjacent to the pancreas. Most of the time, they don't remove the diseased pancreas
Oh, okay.
because that itself is major surgery. So they try not to remove unless there is infection or something like that. Otherwise, they don't remove.
Thank you, Prof.
Any other questions? So if there's no other questions, I'd like to thank Professor Nasir for taking his time on a Saturday to be with us and present a very interesting topic. Enjoy your long weekend, Prof, and thank you very much.